Good morning.
Good morning.
Good to see you all. Thank you for turning out so early in the morning. I want to also welcome those that are online for this event. I'm Aaron Williams, Senior Advisor for Government Relations at RTI, and it's my pleasure to welcome you to this second panel hosted by RTI International on integrated health systems. And today's panel is going to examine how integration can help in maternal and child deaths, a topic that I know is something of great importance to the people in this room and public health practitioners around the world. I want to thank you for joining us. I also want to thank our wonderful panel who's here today. Kelly Saldana, Director, Office of Health Systems, USAID. Richard Reitinger, Vice President, Global Health Division at RTI. Chessa Lutter, Senior Nutrition Researcher also at RTI. And Christina Beeson, our Senior Health Systems Specialist with RTI, who will moderate the panel today. As we well know, integrated service delivery and health system strengthening is a means to improve health outcomes. When designed appropriately, integrated service delivery enhances efficiency, quality of care, quality of life, and customer satisfaction. However, when designed poorly, it can overburden the health workforce, policymakers, and result in poor health outcomes and services. You think about the Ebola crisis as an example. We can now see without a doubt that stronger, more integrated health systems would have helped national governments and frontline health workers in their response to the outbreak. Better health systems could have prevented or slowed the spread of Ebola. Now, the same is true in the fight against maternal and child deaths. It's a global crisis when 300,000 mothers die and nearly 6 million children die across the globe each year. 300,000 mothers, nearly 6 million children. We also know that more than 2.6 million newborns die in their first month, and almost 1 million on the first day of life. I've seen these challenges in healthcare in my career at USAID, at the Peace Corps, at RTI. I know you have seen the same thing as you travel around the world. The world can and we should do better. We need a systematic and coordinated front across technical focus areas, across connected elements of the health systems, across national ministries, and across levels of care to ensure equitable, accessible care. In March of this year, RTI hosted a panel on health systems strengthening. The panelists then explored how we can build the evidence base for integration to concretely demonstrate its value and learn lessons to continually improve efforts. Panelists explored critical areas successful for integration, people-centered approaches, governance, public-private collaboration, health information, and financing. These are, of course, all essential ingredients to a well-functioning primary healthcare system. Today's panel will look at the evidence for integrated health systems. It's this time to focus on how they can help in maternal and child deaths. In other words, the panelists will explore what gains in maternal neonatal health care are made when integration is done effectively, and how to achieve integration. And they will share evidence that demonstrates effectiveness. The panelists will discuss how integration lends to improve health outcomes and share the evidence that integration can help achieve further cost effectiveness, efficiency, equality, equity, and access to services. Finally, after the panel's presentations and a moderated discussion by my colleague, Christina, we welcome your contributions to this topic in a question and answer session. You know, as I think about the times I've visited places like Haiti, Honduras, places where I've worked, South Africa, Indonesia, the time has come for us to take on this challenge in a new, more effective way. And the approaches that we're going to discuss today are ways that we can effectively achieve this. So thank you for joining us, and I look forward to our panel discussion. Okay.
Great. Thank you very much. Thank you, Aaron, and thanks for taking the time to be with us and have those opening remarks and remind us where we are in terms of integrated service delivery and integrated health systems as well. As Aaron mentioned, this is a continuation of a discussion of a really great technical dialogue that we started back in March of this year, of 2017, that really helped kind of unpack and kind of demystify what we mean by integrated service delivery delivery and how that fits within the health systems framework. And we talked about patient-centered focused care. We talked about health financing and governance, as mentioned. And we're going to just take a deeper dive and look at it from a different lens in terms of what gains are made in terms of ending maternal child deaths. So I hope, I'm glad that you came, and I'm really appreciative of all the people that were also registered on the webcast. I think we have some 150 plus people on the webcast, so I wanted to acknowledge the time, and particularly realizing that we sandwiched this in between just coming back from the Labor Day and starting of school, and then right before UNGA. But we do think it's timely, and we do appreciate your time as well for such an important topic to help us really understand what this means and figure out what this means at the country level as well. So I'm going to introduce panelist by panelist, and we'll give them about 15 minutes or 20 minutes to talk to us about their particular focus area, and then open up the dialogue in terms of questions and comments, and really try to get a technical discussion going as well, and get you out of here by about 11 o'clock. So first, I would like to introduce Kelly Sadana. She's the Director of Office of Health Systems at USAID's Bureau of Global Health. She has over 15 years of experience in terms of public health administration and international development. She's served in various roles with USAID at the Office of Health, Infectious Disease and Nutrition, Maternal Child Health Division, and also at the Bureau of Latin America and the Caribbean. She's led a wide array of health programs throughout her career, including the Haiti earthquake response, and more recently, USAID's Zika response. She's also developed with her colleagues at USAID the agency's approach to acting on the call, which is a report published to demonstrate the work being done by USAID and its partners to end preventable child and maternal deaths. She holds an MPH and an MPIA from the University of Pittsburgh. So welcome, Kelly. Thank you for joining us.
Thank you.
Mm-hmm.
Okay, I want to thank RTI for hosting this event, and for having the opportunity to have this really important discussion about how health systems can contribute to integration and to end preventable child and maternal deaths. So are the slides? Okay. Where do I point? Oh, it's not on. Sorry. Not my fault. Okay, sorry. So as Christina said, the Acting on the Call is our annual effort to show progress in ending maternal and child deaths. We think that the effort in and of itself is a form of integration because it explicitly recognizes the contribution of various health programs towards one goal, which is ending preventable child and maternal death. So it combines the forces of our programs in maternal and child health, family planning, nutrition, and malaria primarily. Over the series of reports that we've done, we view it as sort of a continual improvement and refining process of our overall approach. So the report we published in 2014 demonstrated how high impact interventions scaled up on a best performer level could achieve could save 15 million children's lives and 600,000 women's lives by 2020. In 2015, we really focused in on the maternal and newborn component of that and highlighted how those interventions work together in a high impact way when scaled up to help achieve that result. In 2016, we turned our report to focus more on new approaches to being able, within that overall construct of high-impact interventions, how would we accelerate this progress, and demonstrated that by focusing on the bottom 2 quintiles, we could achieve those results if we were able to achieve reductions in the bottom 2 quintiles. And finally, this year's approach, we take it a step further and look at how health system strengthening combined with a focus on high-impact interventions and equity really helps to address and accelerate this progress. We look at the common health systems bottlenecks that can impede progress towards maternal and child health goals, but also a range of other health issues. And through our focus on these bottlenecks, we were, for the first time ever, able to calculate a quantitative value of lives saved due to health systems interventions. We estimated that by investing in health systems, we could contribute to saving the lives of 5.6 million children and 260,000 women over the period from 2016 to 2020. And we know that successful health system strengthening efforts are country-led and country-driven. In other words, national and local governments, private sector, and civil society all must feel accountability for the strength and stability of their health system. And really, at its heart, health system strengthening in the broadest sense is the ultimate integrative approach, because our health system strengthening interventions have benefits that accrue across all programs and help foster sustainability and put countries on a path towards universal coverage and where they can sustain gains independent of donor assistance. So within USAID, we're also moving forward in using a systems thinking approach to our health systems interventions. So through this approach, we want to focus on and understand the links and interactions between the core health systems functions, to analyze how they come together to impact maternal and child survival. And so really, it's integrating further across the health system's building blocks, not looking at a siloed approach building block by building block, but recognizing that the best improvements in any area draw from across the strengths of the 6 key building blocks. For example, in Ethiopia, USAID supported health facilities to combat antimicrobial resistance by working to reduce unnecessary prescriptions of antibiotics that resulted from presumptive or symptomatic treatment of malaria. We used a continuous results monitoring system to track indicators around access and use, but combined that with supportive supervision and feedback for health workers. And to do that, we helped move facilities away from presumptive treatment and instead to only provide malaria treatment following lab-confirmed tests. Several facilities have become so adapted at this that they've graduated from USAID support in Ethiopia and continue to implement the effort. So while our efforts to end preventable child and maternal deaths have focused on improving efficiency through the scale-up of high-impact interventions and service integration, the focus of health systems in this year's report also identifies a few other approaches that we think can help integrate across the health systems and health service delivery platform to accelerate progress, and I just want to highlight a couple of those. The first is social and behavior change integration. Social and behavior change integration is defined in 2 different ways. First is SBC integrated into service delivery, or otherwise referred to as service communication. And the second is SBCC integrated across topics, such as using SBC to integrate across family planning and immunization, or HIV and TB, to both improve behavioral outcomes and improve the efficiency for providers and clients. So service communication is the use of social and behavior change communication processes and techniques to motivate behaviors related to health service delivery among all intended audiences and across the continuum of care, so before, during, and after services. Integrating SBCC into service delivery projects gets more clients to health facilities, includes client-provider interactions, and increases the adoption and maintenance of healthy behaviors. Strategies for social and behavior change focus not only on communication, but approaches such as behavioral insights into improve the framing of choices to overcome bias, or interventions to instill a new habit or directly suggest or positively reinforce decisions to achieve positive behavioral outcomes. So we're really working with behavioral sciences to provide knowledge about how to improve service delivery from a behavior change focus. And this includes approaches from using opt-out approaches, testing, reminders that are emotionally based, and other forms of behavioral sciences to help achieve health systems objectives. Within SBCC, health systems are the support function or the enabling environment that help behavior change to successfully occur. Additionally, we integrate our SBCC for different clinical areas, as I mentioned, that helps to improve our service delivery integration. So a few additional ones are integrating across the full spectrum of reproductive, maternal, and child health, integrating hand washing and improved child feeding practices, integrating population health and environment activities, so really using behavior change. Another example from PMI helps to illustrate this point. In Uganda, PMI collaborated to design and execute a test and treat campaign. The campaign had 3 main objectives: build trust in malaria test results among clients and health providers, increase the proportion of clients with fevers who are treated appropriately, and encourage community members to get children under 5 tested for malaria before treatment. The campaign was rolled out in 24 health districts where malaria is highly endemic, and the result was a shift in provider behavior. Those who were trained and exposed to the campaign were more likely to conduct a differential diagnosis, less likely to prescribe anti-malarial drugs for children with fever who tested negative, and finally, the providers that received clinical training that included interpersonal communication, counseling skills, were more likely to tell caregivers that anti-malarial treatment wasn't necessary after a negative test result and to provide an alternative diagnosis. In addition to this, the campaign also improved the availability and stocking of malaria drugs, making drugs available for people who actually had malaria. The second integrative approach I want to talk about is community systems. It's often underappreciated aspect of health service delivery is that the community members themselves have a role in the ownership and generation of their health. The foundations of community health within primary health care are increasingly recognized as crucial components of national policies and strategies to accelerate progress in health. We need to further integrate community health systems approaches into national and local health policy and systems in order to achieve our health goals, especially those related to maternal and child health. The integration of community systems with health systems is accomplished through partnerships. USAID works with governments and civil society to define common approaches to strengthen community systems by engaging communities as partners in primary care systems. They also empower communities so that they're involved in the processes and the health systems to ensure that health services are people-centered. For example, in Mozambique, we worked to revitalize and establish community health committees that promote linkages between communities and health facilities. In eastern Indonesia, we linked maternal and child health efforts in remote centers to district and provincial level planning systems. Okay, the next approach I want to talk about is the total market approach. This primarily draws from the work that we've done in our family planning programs, but more and more we think that this approach is useful across our portfolio. In many countries, we know that public and private sectors have acted independently to deliver health services with limited coordination and partnerships, despite the fact that the private sector plays an increasingly significant role in the delivery of health services throughout the maternal and child health service delivery continuum. But there hasn't been enough recognition of its potential to contribute to national health objectives. Therefore, most importantly within family planning, but like I said, increasingly across our portfolio, USAID is looking towards a total market approach as a critical component of health system strengthening to improve maternal and child survival. There is growing consensus that active participation of all sectors in health system strengthening is crucial to achieving long-term sustainability and health systems resilience. So a few of the contributions that at a time of shrinking resources can be gained by integrating the public and private sectors through a total market approach include facilitating government stewardship for services, ensuring public sector subsidies are targeted to the poor and vulnerable in cost-efficient and effective ways, reducing or removing untargeted subsidies for those segments of the population that are willing and able to pay for non-subsidized products and services, fostering evidence-based decision-making, especially related to the public sector forecasting of needs and market realities, and establishing cost recovery strategies with the nonprofit sector to reduce donor subsidies. So an example of this is, as I'm sure you're all aware, USAID has led the donor community in actively encouraging a stronger role for the private sector in providing supply chain services to ensure that family planning and health commodities reach health facilities and end users. The use of the private sector for supply chain services strengthens health systems by accessing capacities which typically do not exist in the public sector. Strong supply chains allow efficient delivery of high-quality contraceptives and related health supplies to clients when and where they need them at an affordable cost. And assuring a family planning workforce that is well-trained, responsive, fair, and efficient results in achieving the best outcomes possible. Of course, I can't not mention that we also promote an integrative approach through service delivery integration, which I think was the subject of the last panel, so I'm not going to dwell on it too much, only to note that within service delivery, we focus a lot on the point of service and the health workers to help with the integration across service delivery. Health workers need to be continuously supported to deliver a quality standard care through effective policies and evidence-based approaches. health systems approaches which ensure the workforce has the tools to deliver quality care services, and empowered to act on deficiencies in service delivery are key examples of cross-cutting health systems approaches which have the potential to have a wide-ranging impact. So for example, in India, healthcare workers knew that breastfeeding and kangaroo mother care or prolonged skin-to-skin contact were lifesavers for newborn babies, yet they weren't really seeing the improvements as expected from implementing this approach. So we worked with them to implement a 7-step process to develop a quality improvement team, identify issues, identify the cause of the problem, test and measure the success of the solutions, all using the actual health workforce that was delivering the services. They identified that they weren't providing enough hours of kangaroo mother care was the main problem. And so the team decided that allowing fathers to spend the night and placing more comfortable chairs in the newborn room would increase the amount of time newborns spent in kangaroo mother and care. So this is just an example of a team-based approach that once health workers have the skills to identify and analyze problems and come up with their own solutions can be applied across the health portfolio. So now I'm going to turn a little bit more to discussing the methodology that we have in the report, building off of the example around service delivery and health workforce, which are the 2 examples that our report demonstrates within health systems have the biggest impact on lives saved. I believe that's a bit intuitive, given that those are the most direct and closest to private client-provider interaction. So the modeling done from this report began in 2014 when USAID, through the Health Governance and Finance Project, did a full literature review to identify studies and peer-reviewed literature which directly linked health system strengthening interventions to a series of health outcomes. Building on that work, we convened 28 experts from 10 countries and 6 continents for 3 days to look at 130 systematic reviews representing 2,000 individual studies. And so they found these 29 interventions within health systems that could be related to health outcome impact, and then collectively decided on the effect size or the effect size range from each of those interventions. We then, looking at, sorry, you can't see that very well. So then, in order to model for our report, we first analyzed key bottlenecks within health systems, like financial affordability, human resources availability, that sort of thing. We verified the information about to what extent the bottlenecks in a low, medium, or high scenario were impeding progress at a country level. And then we asked countries which of the 29 strategies were being implemented in country or expected to be implemented in country, and to what level they expected to scale them up. Using all of this information and the EQUIS tool identified by UNICEF, we were able to figure out the impact that health systems interventions were expected to have on the key health systems bottlenecks, and then the impact that would then have on the key interventions. Then we used the list tool to scale up and model the impact of lives saved based on the coverage changes in interventions modeled from the work based on the health systems interventions. So I can talk more about that if people have more questions, but that's basically how we got to our results. We like to call them an ambitious best case scenario. So we asked our country teams to identify if they had, everything, if the stars aligned with what was being implemented, how much could they scale it up over 4 years? And then because it's based on the reality on the ground, each intervention is done sort of in collaboration with all the other interventions. So no one result up here could be taken in and of itself. It's all the combination of all of the interventions that each country talked about being scaled up together. So it's not necessarily a prioritization exercise, but it demonstrates the potential of these individual interventions on lives saved. So for example, on here, you'll see some bars might be lower and some bars might be higher, and that could be for different reasons. One could be that the underlying bottlenecks were not as severe, and so therefore a scale up didn't have much impact because you already had good availability of human resources, for example. Two, it could mean for a lower bar that a particular intervention was already being implemented at or near scale, so therefore didn't have that much farther to scale up. Or three, it could be that that intervention is recently being introduced and only expected to be scaled up a small amount over the next 20 years. So really, we use this report to help demonstrate the impact of health systems, but to really take and act on these interventions, you need to understand the country context and what is happening within country to translate that into actual action. So this is the example from Indonesia. And just to build on the example that you're seeing here, we see that health systems accountability is one of the activities that wants to be scaled up in Indonesia and which will really make a difference. And we have evidence of this from our prior work in Indonesia. In 2011, with help from USAID, civil society organizations successfully advocated to the government of Indonesia to prioritize the reduction of maternal and newborn deaths, which led to designated funding for more trainings and a hospital referral system, including training to manage obstetric emergencies like severe preeclampsia. Since 2011, the program has been introduced in 30 districts and cities, including 150 hospitals and 300 health centers. So we've already seen impact from work on accountability in Indonesia, and we can see from the modeling that we expect further impact as we scale it up. We're also able to use the report to look at expected impacts on quality of care. So this is an example from Nepal. And you see that because the impacts on the scale up of each of the 29 interventions translates into changes to bottlenecks and intervention coverage, we were able to to disaggregate that by expected changes in scale up across the quality of care continuum. So from basic health services to quality health services, and finally to basic to improved to quality. So for example, and then we did that across 4 service delivery platforms. So those are curative care for children, delivery care for women, preventative services, and then community-based and outreach services. Because as you imagine, the bottlenecks affect those different platforms differently. So this is an example of, in Nepal, how we are scaling up access to delivery care, the delivery care platform through the scale up of interventions. So at the basic level, it would be delivery in a facility, but not necessarily a facility equipped to handle emergencies. At the improved level, it would be delivery care at facilities equipped to handle basic obstetric emergencies. And at the quality level, it would be expected deliveries in facilities that were capable of handling comprehensive obstetric emergencies. So that's, and as you go through the reports that are on your chairs, you can see an example of this on a country-by-country basis. So finally, what is the way forward? We think that ensuring the gains made in progress towards maternal and child mortality can be sustained and built upon to expand primary health care and promote universal health coverage through our efforts to promote equity. So again, this is where we've built on all 4 of our Acting on the Call reports. Last year, we identified the progress from focusing on the bottom 2 quintiles. This year, we look at health systems. But it's really both of those approaches together that we think will help to maintain the gains and sustain the progress. So looking at our health systems interventions for how they can help us continue to reach the bottom 2 quintiles or people who are otherwise excluded from health services. So we need to look at what are the root causes of inequities, which not always are based on wealth. So, for example, women with HIV or limited financial means may experience disrespect in health facilities and therefore may not want to attend them, may be discouraged to seek care. At the same time, we know that high out-of-pocket costs prevent the poor from receiving treatment, but we also know that children living in remote communities or away from health centers may miss out on life-saving immunizations. So we need to look at what is causing inequities in order to make sure that we're reaching those that are excluded excluded for whatever reason that they're excluded for, and to help break cycles of poverty, which will help us lead to stronger, healthier, more prosperous societies. USAID's health programs promote equity and social inclusion in a variety of ways, which are detailed in last year's report. So in highlighting the issue of disrespect and abuse, identifying solutions, addressing needs of patients and providers, providers not having the equipment and supplies they need to provide health services is another form of inequity, and through quality improvement teams, as I mentioned before. So finally, just one last example. From a USAID-supported multi-component intervention in Kenya, we were able to show that interventions in the facility and the community resulted in a decrease in abuse of women during delivery from 20% to 13%. So again, I think by integrating our approach and having one common goal for ending preventable child and maternal deaths, and then working to achieve that goal through the scale-up of high-impact interventions, targeting inequities where they occur, and focusing on health systems is the way that we hope to achieve an end to preventable child and maternal deaths. Thank you.
Thank you. Thank you, Kelly. That was great. And really kind of covered not only just a great explanation of USAID's approach across helping end maternal child deaths, but really helped me personally better understand kind of the numbers and the methodology as well behind it, and those concrete examples were great. So I appreciate that, and I really am happy. I'm sure that you all too, are really glad to see that primary health care is front and center, and also that we're really understanding what that means in terms of the patient-centered approach. And it's really about really optimizing it for the person. It's following that person across their spectrum of life, across their continuum, not necessarily the disease, but the actual mother, the actual child. And so when and if we have the need to bring in other things that are that they are burdened with, such as non-communicable diseases and the like, then we have that opportunity, we have that platform to create that quality of services. So thanks a lot, that was great. There's still some room in the front. If you all, if people don't have a seat, please feel free, don't feel shy. Make yourself comfortable. So thank you very much. So I want to introduce the second panelist, Richard Rathinger, who is the Vice President of the Global Health Division, who leads the Global Health Division at RTI International. And he's going to take a different lens and focus on malaria. And it was great that you provided an example. So you all were co-advocates for really the inclusion of effective interventions for malaria. Richard Rathinger is an internationally recognized leader in the field of malaria and other vector-borne disease epidemiology, case management, prevention, and control. Prior to working at RTI, Richard served as a PMI's Presidential Malaria Initiative team leader and malaria advisor for USAID Ethiopia. Richard is an epidemiologist and with experience managing multi-country infectious disease programs in Africa, Central Asia, and Latin America. And he's published more than 100 peer-reviewed papers in international medical and scientific journals. He serves as malaria focal person for the Globals Fund Technical Review Panel. He holds a PhD in epidemiology and a Master's of Science in Medical Entomology from the London School of Hygiene and Tropical Medicine, as well as a postgraduate degree in economics from the University of Sussex. Welcome, Richard. Thank you.
Well, thank you, Christina, for this welcome, and welcome to everyone here to today's session. So Christina asked me to kind of dive a little bit deeper into how malaria case management has an impact on integration of health services. And equally, one could also rephrase the title as the impact on integration of malaria case management. So it's kind of a bi-directional relationship that I would say, not just unilateral. In terms of main talking points, For me, for today, there's how does integration of malaria case management into overall health service delivery programmatically occurs, and then also how does integration need to happen more effectively in order to ensure continued progress on the main malaria metric indicators. To provide you a little bit of context, really the landscape for malaria programming changed in the early 2000s when the Global Fund for AIDS, Tuberculosis, and Malaria got established, and then in 2005 with the launch of the US President's Malaria Initiative that Kelly already mentioned earlier. And due to those two initiatives, there was a massive scale-up of malaria interventions that occurred. Sort of from the mid-2000s onwards. Of the main malaria interventions, so these are insecticide-treated nets or long-lasting insecticidal nets, indoor residual spraying of households with insecticide, then the intermittent preventive treatment of pregnant women with sulfadoxin pyrimethamine, then also the rapid diagnostic tests, and the artemisinin combination therapies, which is the main malaria drug against uncomplicated malaria. So all of that happened between 2005 and sort of 2010-ish, but it actually was quite a while until then there was some global guidance from WHO on really ensuring that every suspected fever case does actually get tested before getting treated. And that was the T3 or test, treat, and track policy guidance that came out in 2012. And in terms of case management, since really sort of 2010-ish onwards, we then had an even greater scale-up of case management efforts in malaria endemic countries. So both in terms of diagnosis, but then also, of course, treatment. Also, again, IPTP. And then also recently, seasonal malaria chemoprevention in those countries that are eligible for it, which is essentially a monthly dose of antimalarial medicine in sort of a mass drug administration type of approach. And really, I think those kind of interventions combined with the aforementioned interventions like bed nets, like IRS, have already substantially reduced the malaria burden, both in terms of morbidity as well as mortality, and we hope will continue the progress already made. And so here is on my next slide a few of those malaria metric indices, and so you can see how really there's, of course, the BedNet access and use that has substantially increased between 2010 and 2015. Then also the IRS coverage has stagnated somewhat, primarily because of insecticide resistance and the cost of that intervention increasing substantially in the past few years. But then you see the last three indicators really are with regards to case management. And so access to care for children under 5 has increased dramatically, as has the diagnostics coverage to almost 80% now. And then also the treatment coverage for children under 5. So children under 5 that have a fever, go to a health facility, get diagnosed, and then get treated with an antimalarial drug. Now, the last indicator, however, you can see has still quite a lot of room to grow and is really going to be a focus for the years to come. But the interrelationship between sort of case management and mortality can really be shown on well, this is actually the ACT coverage, so this is just to illustrate how that has gradually increased from 2005 to 2010 and then 2015. And you can also see that there is great variability, of course, in the country's ACT coverage over the years. What does that mean in numbers? So just for 2015 alone, 179 million rapid diagnostic tests have been procured to really underwrite that push in terms of scaling up diagnostic testing of suspected cases, together with 148 million dosages of ACTs. And all of this has resulted in quite a decrease in malaria cases and malaria deaths. So even though in 2015 we still had 191 million cases of malaria, that's a reduction in incidence of 21% since 2010. And in terms of deaths, we still have 400,000 deaths almost, but since 2010, that represents a 31% decrease in the number of deaths per year. So you can see that since 2010, there's been quite a progress that has been done, much of which has also been contributed to by case management. Now, in terms of competing trends and challenges and opportunities sort of in the case management realm, I would say I wanted to kind of put out a number of points to hopefully inform the discussion that we're going to have later, as well as the questions and answers session that we're going to have after the moderated discussion. So where are we now? So in terms of country policy, environment, and health service delivery infrastructure, most endemic countries have now adopted a policy of providing malaria diagnosis and treatment to all age groups. So previously, there was a differentiation between the age groups and who would get diagnosed and treated. For example, for a long time, countries presumptively treated children under 5 rather than testing them. And also, most countries now have policies around providing ACTs free of charge. But even though we have this framework in place, of course, when it comes to the operational programming, there's still quite a gap, and millions of people still lack access to appropriate treatment. And for example, one of the indicators, which I didn't show before, children under 5 with fevers that do have not, or that actually aren't seen, so they never make it to a healthcare facility, is actually also quite high at, I believe, 36%, if my recollection is right. So again, quite some room to improve there when it comes to programmatic aspects around case management. And so the relationship between case management and mortality is shown on this map, which comes from a study by Getting et al., who really show how in those countries or in those geographic areas where treatment is low, there is that inverse relationship with mortality related to malaria. So you can see that in those areas that are sort of reddish or orange, darker orange, treatment is low, and then of course mortality per 10,000 population is much higher. And then in blue, you have sort of a similar graduation of low treatment rates, and then mortality being between 10 to 20% per 10,000 population. A second trend is really the difference that community health worker platforms have made. And really the point of integration there being that, malaria programs in the early 2000s were very vertical, but over the last 10 to 15 years really have integrated in these community health worker platforms that have been rolled out in numerous countries. And I would say that those countries that have seen greatest progress in reducing the malaria burden in terms of morbidity and mortality have been those countries that have really successfully integrated malaria case management in their community health worker platforms. So a lot of countries have these now, but not all of the countries have them fully functioning. So I will come to the example of Ethiopia later on, but there are other countries such as Senegal, Kenya, and so forth that have very well-functioning platforms, whereas other countries like Tanzania or even Mozambique have platforms that are much more limited, and that's where some of the Malaria Metric programmatic indicators in terms of diagnosis, treatment, and also morbidity and mortality have been progressing less well than in the aforementioned countries. Then a third big issue or competing trend and challenge is around the proportionate allocation of malaria case management in the public and private sector. So in many countries, the public sector is the driving service delivery arm when it comes to malaria case management, but there are certain countries where that's not the case. And of course, case management in the private sector, when it comes to regulation, when it comes to quality of service, supervision, data collection, use of the various commodities can be quite varied. So you have countries like Nigeria where 50 or 60% of all malaria cases actually do seek care in the private sector, where actually diagnosis is not necessarily done. So treatment is done very much presumptively, which, to be honest, 10 to 15 years after sort of the scale-up of interventions shouldn't really be the case anymore. And as you can imagine, Nigeria being the most populous country in Africa, if 50 or 60% of all malaria cases there go to the private sector, in terms of commodity cost, just for ACTs, Nigeria's budgets, it's in the $120 million per year. So that can have quite a financial consequence as well. Then we, of course, with malaria case management, have the issue around drug resistance, something that has to be very closely monitored. Kelly mentioned a little bit of the work that USAID has supported in Ethiopia around pharmacovigilance and quality antimalarial drugs. Fortunately, right now, resistance is very much constrained to the greater Mekong subregion. But nevertheless, that doesn't mean that in the other malaria endemic areas, we don't have to make sure that essentially the risk of resistance developing is minimized. And lastly, as programmatic impact of the intervention continues, what we will also see is that actually case management will become even more important. And the reason I say that is that of all the cases of fever, malaria only represents a certain proportion. You have other causes of fever like pneumonia, like respiratory infections, and so forth. Now, in very highly endemic malaria countries, the proportion of fevers that are due to malaria is going to be substantial, 40 to 50%. And of course, there might also be a seasonal variation during peak transmission season when that proportion goes even higher. But as we are making progress against malaria, the proportion of fevers that are actually due to malaria is going to go down. And so really what needs to happen is that case management, not only for malaria, but also for these other etiologies of fever, gets strengthened as well. And I'll come back to that later in sort of the case study that I lined up, where, for example, approaches like integrated community case management of malaria become important, so that health workers do have other options if, for example, a suspected fever case tests negative. And the health workers are not pressured to actually give an antimalarial drug because the family member of, let's say, the child that has the fever that came to the health post wants something for their child to be treated. And this is, for example, a study that has been done in Tanzania, where actually they looked at more than 1,000 cases of fever. And so this is an area, Dar es Salaam and Ifakara, where traditionally there might have been 20 to 30% prevalence of malaria. But now the proportion of fevers that are due to malaria is actually quite low at 10%, and you can see that other causes like pneumonia, like respiratory infections, contribute much more to the fever burden that is seen at health facility level. And we expect to as I said, that proportion to go down even further as progress is made in many countries. So I briefly wanted to take a few minutes to talk about Ethiopia and the work there that has been done. Kelly already mentioned an example from Ethiopia, and I see a couple of people that have been in Ethiopia, so they will have to indulge me, but it is quite a fascinating story to tell, and was quite a privilege to be there at that time. So Ethiopia was a real fertile ground for malaria programming. There was tremendous government leadership where essentially the government in 2006 developed a comprehensive health sector development plan, which had a core element at its sort of as its foundation, which was what they called the primary healthcare unit. That also included the health extension program. So this was essentially a strategy that was devised by the government to really expand dramatically the health service delivery coverage to the Ethiopian population, and particularly the rural areas. So the idea was that in each district of the country, there would be at least one secondary health center, and attached to that health center would be satellite health posts that would be essentially in each municipality. There would be one, and each health post was staffed by 2 salaried so-called health extension workers, which are essentially your community health workers. So there were 30,000 of these health extension workers, and they implemented a package of 16 promotive and preventive activities, including malaria, at first presumptive treatment of malaria, but then gradually confirmatory diagnostic testing with rapid diagnostic tests, and then also, of course, then treatment still. Linked to that health sector development plan, there was also a very strong, comprehensive malaria strategic and policy framework in place. And then, of course, in Ethiopia, for those of you that have been there and have worked there, let's put it this way: the government usually doesn't do things halfways. If they commit to something, they definitely go for it, and it's in a way a risk, what I would call a risk-reward stance. They had this vision of establishing this health extension platform, and they just made it happen. Now, not that a few things ached and broke in that process, but certainly there was this political commitment that was very crucial. Of course, external donor support with the Global Fund, as well as the US government through PEPFAR, PMI, as well as the Maternal and Child Health Funding, DFID, the EU, World Bank, and philanthropies helped enormously. And then also other stakeholder community, the implementing partners, local and international, that contributed to sort of the programmatic success. So in terms of points of integration, at national level, the government decided that National Malaria Control Program, we don't want it anymore, out. So that, in a way, was quite a strong signal, moving from essentially sort of a vertical approach to a much more horizontal approach. not that there were a lot of people, as I mentioned earlier, that sometimes groaned about this decision, but I think it really helped to change the sort of thinking around how malaria programming needs to be implemented and how it really should be integrated and leverage all these other platforms that were implemented at the same time. Then at zonal and district level, in terms of case management, really what happened was to strengthen the procurement and supply chain management. For example, by using very detailed district-level microplans that allowed to then aggregate all the gaps and needs that districts and health facilities had in terms of malaria case management to regional level and then ultimately national level, and get a much better estimate of the commodity needs that were required for case management, rather than having sort of a more traditional top-down approach that really didn't have necessarily any connection with what was needed at health facility level. At the same time then, the government and the partners strengthened malaria laboratory diagnosis at hospitals and health centers. And the decision was made to ensure to strengthen sort of laboratory services, partly because they wanted to leverage other efforts that were going on. For example, PEPFAR was very much supportive of strengthening laboratory capacity at hospitals and health centers. So hooking sort of into that effort, but also acknowledging the fact that actually malaria epidemiology in Ethiopia is very heterogeneous. So there are areas, for example, above 2,000 meters where you don't have much malaria. So fever cases are unlikely to be due to malaria. So really, just having an RDT and testing people for malaria, yes, will help you to obviously rule out malaria, but it won't help you to then really identify what that cause of fever is. And so they really, sought to strengthen that laboratory service capacity, on top of then really introducing and then scaling up RDTs at community level, as I mentioned earlier, with the health extension workers, and also providing them with ACTs. Also, after they had started that, a couple of years afterwards, they actually switched from having single species RDTs to multi-species RDTs. Ethiopia is slightly peculiar in sub-Saharan Africa that about half of the malaria cases are actually caused by Plasmodium vivax rather than Plasmodium falciparum, which is the species that really causes most of the deaths globally. And because these two species have different treatment regimens, you actually need to distinguish the different species that do cause malaria, and hence they made that switch. And then in 2009 to 2011, they introduced and scaled up integrated community case management of fever, and importantly, really made sure that health extension workers didn't only have the RDTs and the ACTs, but also antibiotics, antipyretics, and so forth, so that they did have tools to prescribe when cases tested negative. And then in 2013, they also introduced and scaled up rectal artesunate for pre-referral of severe malaria cases. Now, additional points of integration that aren't necessarily around case management, but obviously Kelly mentioned also other ancillary efforts such as social behavior communication that needs to happen, as well as, of course, capacitating the health workforce in the correct case management practices and so forth, as well as then, of course, distribution of bed nets through health workers that happened there, and ultimately also strengthening the health management information system to make sure that all facilities that do provide case management are actually reporting data from district or community district regional level up to the national level. Now, with Ethiopia, one has to note that unlike in other settings, there's no intermittent preventive treatment of pregnant women, nor is there also bed net distribution via antenatal care, which in other countries can be further points of integration in sort of the wider health system when it comes to malaria programming. Now, in terms of impact, all of this scale-up of malaria interventions, including case management, has had quite an impact on malaria burden in Ethiopia. Before 2005, there probably were around 10 million annual cases, of which less than 5% were confirmed. Actually, in 2004, they had a very large epidemic that caused 25,000 deaths. And then with all that scale-up of all these activities that I mentioned before, they have now, as of 2015, no major epidemics have been reported. Malaria prevalence is essentially less than 1% in most of the country. There are still quite a few number of malaria cases, 2.4 million, however, of which 86% are now confirmed. So you can see that in a span of 10 years, they went from less than 5% confirmed to more than 85% of cases confirmed. Also, what's critical, and this kind of points to sort of the equity issue sort of aspect of things, is that 2/3 of the cases are actually diagnosed and treated at health post or community level, which again is very important given where the program was before. And that also means that there are much fewer admissions now than there used to be, about 16,000 admissions and less than 500 deaths. So think about less than 500 deaths for 2.4 million malaria cases is nothing. And essentially that kind of tees up Ethiopia now to be sort of in really the path to malaria elimination when it comes to incidence of cases and deaths. So challenges going ahead when it comes to case management. There is the epidemiological profile in Ethiopia that will continue to change. Interestingly, when we always talk about malaria, it's children under 5 and pregnant women that are, of course, the at-risk groups because they're biologically more susceptible to severe disease. But actually in Ethiopia, children under 5 and pregnant women aren't the greatest proportion of malaria cases anymore. So you do have now other age groups, whether children above 5 years of age or adults, that represent a greater proportion. Actually, 80% of the outpatients and inpatients malaria burden is now among adults and children who are greater than 5 years of age. What we also are likely to see is that the ratio of Plasmodium falciparum to Vivax is going to shift, and that will have to require a rethink of the sort of treatment or case management approach. And then, of course, there's the increased probability of outbreaks as immunity to malaria will wane as well. At the primary healthcare unit level, there's still room for improvement. The current ratio of tested versus confirmed, tested and confirmed versus treated with ACTs or presumptively treated with ACTs is still 1 to 0.5. So really in the Ethiopia setting, probably you would say that of all suspected fever cases, 10 to 15% would be due to malaria. Probably less or most likely less in certain areas. So you can see that there's still quite a lot of presumptive treatment or over-prescription going on. That is obviously a behavior that needs to change and be improved, and is also linked, sort of, as I said, around the compliance of the test results. So in summary, and this is not, I would say, rocket science, but I would say it's always surprising to me how, even though these main ingredients for successful integration and programming are quite straightforward and simple, there are actually very few areas where all of these come together and sort of create sort of that ideal scenario and home run. So country leadership is a must. Strong stakeholder community is critical. And then there really needs to be sort of that presence of functional operational platforms to hook into, such as, for example, the community health worker platforms. There also has to be an element of being able and having the courage to take risks. You definitely see countries that have essentially made, for example, the switch to scale up RDTs and ACTs early, have fared much better than those that essentially have waited because of one or the other reason, whether it's a policy reason or funding reason or another programmatic reason. And then also there has to be, of course, the comprehensive monitoring, evaluation, research, learning and adaptation approach that allows to really monitor programmatic implementation and allow for course corrections. So that's it. So any questions, please don't hesitate during the question and answer section. Thanks.
Thank you. Thank you. Thank you, Richard. And yes, I did forget to mention that try to save all of your comments and suggestions and questions. I hope you're writing them down because at the end of following Chesa's presentation. And thanks again, Richard, for pointing that out. I loved the technical depth and really understanding and unpacking what we mean by kind of case management and how that, really fits in with integration, and that we're certainly not talking about an amalgamation of services for one provider, but it's really a coordinated front that starts at the country level from policy to facility to community, and it was particularly interesting to hear about the kind of the differential diagnosis and the support in terms of helping figuring out the other reasons that mothers and children have fevers and helping that understand and the reasons behind that, and really could support the health workforce, but also support the bottlenecks too, or confront the bottlenecks that happen. So that was great. And likewise, understanding, if we don't do it well, what can happen? For example, the case in point that you mentioned in terms of the costly effect of when we do it poorly, for example, the cost and the financial consequences that you mentioned in Nigeria were really interesting. So fascinating. So thank you for that level of depth to that. That was fantastic. So we're going to transition to another colleague of mine, Chesa Letter, to talk about the nutrition part of it and what nutrition means for early childhood development. So I'd like to introduce my colleague Chesa Letter, who has worked for more than 25 years on policies and programs to improve maternal and child nutrition in lower and middle income countries. After a 19-year career as a senior advisor for food and nutrition at PAHO, the Pan American Health Organization, she currently serves as a senior nutrition researcher at RTI International and is also a visiting research professor at the School of Public Health, University of Maryland. Her many peer-reviewed papers, I think she's got about 100 as well.
No, we don't. Richard, he's got more.
On child growth, breastfeeding, complementary feeding, and child obesity have appeared in major nutrition and health journals. Chesa holds a PhD in nutrition from Cornell University and a BS in natural resources from UC Berkeley. Welcome. Thank you.
Thank you very much. Good morning. Thank you, Christina, for such a nice introduction, for all those extra papers that I published. It's a pleasure to be part of such a distinguished panel, and also to have recently joined such a strong cadre of nutritionists here at RTI. Really looking forward to really strengthening and expanding our work in the area of infant young child feeding, prevention of overweight, and other aspects of nutrition. So let's see if I can do this without turning it off again. So while the title of my talk is What Integration Means for Early Childhood Development, I took the liberty, as Richard did to some extent, and changed my title a little bit. So I'll also be addressing the role of young child nutrition and feeding as it contributes to, benefits from, and interacts with early childhood development. And I think, moving on, obviously malnutrition is a big contributor to child mortality. But we're really starting to also look at, survive and thrive. We want these children not to die from malnutrition, but we also don't want them to be compromised throughout their life. We want them to reach their potential and contribute to their societies as they develop. So I will be focusing or have comments into 3 different sections. I'll begin by a model to show the relationships and linkages between nutrition and early childhood development. And then I'll follow with 2 specific examples of how young child feeding and nutrition can be improved through integrated healthcare models. So the period that young children are at greatest risk of undernutrition coincides perfectly with the most sensitive periods for brain development, really showing the intrinsic link between the two. The figure on your left shows that the risk of undernutrition is greatest during the first 2 years of life, the prenatal period, and the first 2 years of life, which has been coined the first 1,000 days. And the timing of growth failure, including low weight for length, which is the red line, low weight for age, the green line, low height for age, the blue line, is illustrated, as I said, the figure to your left. It uses Z-scores, which I won't go into details, but it expresses these values as standard deviations above or below the reference median value of the WHO child growth standards. Although it's not shown in this figure, it is estimated that about 20% of stunting or short stature in a child occurs prior to birth during the prenatal period. So length and weight at birth is not just a function, obviously, of prenatal nutrition, but the overall health of the mother during her pregnancy. And so again, speaking to both the role of nutrition and health services and their integration as it relates to good birth outcomes. The figure on your right shows that the sensory pathways related to vision and hearing, the orange line, language, the blue line, and higher cognitive functions, the red line, also occurred during the first 1,000 days. Quite a profound overlap. The scale for age is not the same in the figure for early childhood development, so I kind of just drew the little orange line in there to show the child at 59 months of age, so you could see more clearly the absolute overlap. Okay. So there's 4 domains that contribute to early child development. And these are really the motor development, physical growth, the cognitive and language, and the social emotional. And obviously directly influenced by both brain development and functioning. The recent Lancet series on early child development, our colleague here at RTI, Dr. Maureen Black, was one of the key authors of that series and also helped contribute to these slides, revealed that poor early child development is a global crisis. Over 40% of children less than 5 years of age in low and middle income countries fail to reach their potential. This translates into almost 250 million children. And this failure to reach their potential is largely due to early nutritional and environmental adversities. And clearly, the role of health in those two is fundamental. So nutrition influences early childhood development directly as well as indirectly. Directly, it influences child growth. Good nutrition directly influences both child growth and the development of motor skills. A poorly nourished child, you can think of a child with malaria, for example, will be more apathetic, will not have appetite, and therefore will develop later, walking, crawling, etc. And also when a child is responsibly fed by his or her mother caregiver, She directly interacts during this period and influences the social, emotional child of the child as well as their language development. Nutrition also indirectly influences early childhood development through its effects on brain development and functioning. For example, breast milk is a good source of DHA and other nutrients essential for brain development. Animal source foods such as eggs also contain DHA and other essential fatty acids, vitamin D12, and other nutrients which promote neurotransmitter synthesis and cell membrane signaling. A severely malnourished child has fewer brain cells than one adequately nourished. And there's a large literature on the role of anemia and other aspects of nutritional deficiencies as it affects brain development. Worldwide, about 23% of children, or 155 million, are stunted or too short for their age, and 8%, or about 52 million, are wasted or too thin. And when we think of a malnourished child, our typical vision is of a very wasted child. The child in a hospital that's really quite near death. And this is a serious condition, high case fatality rate, but at the same time, a child can look perfectly normal and yet be stunted. You wouldn't know unless you knew that child's age, how severely really stunted they are in terms of their not just growth, but also other aspects of their development. A recent case when I was in Ecuador, a bunch of young children, I thought they were young children, came up to interact with me in an indigenous community at a high elevation. And as we chatted, the girls, who I thought were 9 or 10, told me they were 14, 15. Again, you wouldn't know unless you knew their age how malnourished they were, and the implications of this for their own well-being, ability to safely deliver a baby, for example. So stunting before age 2 predicts poor cognitive and educational outcomes in later childhood and adolescence. And again, stunting is not just about nutrition. It's very much about health, infectious diseases, symptomatic and asymptomatic illnesses, as well as their interaction. They kind of feed upon each other in a synergistic way to sort of, drive the children down. And again, all this points to the essential role of robust and integrated health services to sort of address both the nutrition as well as the infectious disease causes or other causes of poor nutrition. Not surprisingly, both nutrition and brain development are influenced by poverty as well as a social, cultural milieu. With respect to nutrition, young children require nutrient-dense, high-quality foods. Their stomachs are small, and really to meet, and they have high requirements relative to their weight as they grow during these early years. And not surprisingly, poor families are less able to access these. And also just the cultural environment also influences food choices and feeding modes. With respect to early childhood development, poor families tend to have less time to interact with their young children and provide the enrichment activities as well as safe spaces for them to interact and play. Moving to the home caregiver interactions, particularly important during this time are the provision of early learning opportunities and responsive caregiving, whereby the caregiver is attentive to and responds appropriately to child cues, including cues related to hunger and satiety. And I'd just like to take a minute here to really talk about this whole aspect of responsive feeding. It's just not about the food that the child gets, but how that child is fed and how it relates to their development. So responsive feeding involves the feeding of infants directly as well as assisting older children to feed themselves. The photo on your left shows an example of responsive feeding, and you can see how the mother and the grandfather are really interacting with that child, verbalizing cues, expressing joy, all these different things beyond just getting the food into the child's mouth that will affect their development. It entails, again, not just being responsive to their hunger and satiety cues, but feeding slowly and patiently, encouraging them to eat, particularly when they're ill and don't particularly want to eat, never forcing them, and remembering that really these feeding times are periods of learning and love, and this opportunity then to talk to a child and interact with a child. The photo on your right shows an example of a child left to feed by himself without any interaction with those around him. It's a lost opportunity in many respects. I mean, the child's not getting enough to eat. But also, if you look at the chickens running around, that huge source of infection, E. coli, Campylobacter, and the animals come in and take the child's food. I mean, it's tragic. It's really, really very tragic. So, as I mentioned in the beginning, there are feedback loops between early childhood development and nutrition, as well as between the early ECD and the home caregiver interactions. A child with more motor skills and language is more able to interact with the caregiver, to sort of ask for food, to ask to be engaged with, interact with. And that elicits, more kind of caregiver behavior on, back to the child. A child that can better explore its environment, I mean, just the exploration reinforces critical neural pathways. So what I'd like to do now is move to two examples of how nutrition, and therefore ECD, can be improved through integrated health care. And using two examples, one will be one of my huge passions in life, which is breastfeeding promotion, and the prevention of severe acute malnutrition. So I'm sure this audience is well aware of the many benefits of breastfeeding for babies with respect to lower risk of mortality and many acute illnesses compared to those children who are breastfed less or not breastfed. If we want to talk about prevention of maternal mortality, breastfeeding has a huge role in preventing breast and ovarian cancer. We recently did some estimates on the number of maternal deaths that could be prevented through breastfeeding. We can talk about those later. Less familiar to some, however, are the benefits of breastfeeding directly related to child development. Longer breastfeeding is associated with an average of 3 or more IQ points, as well as improved academic performance and increased adult earnings. And as part of a writing team I was involved in for a 2016 supplement on breastfeeding that we did, we sought really to reframe the narrative as breastfeeding is a sole responsibility of a woman, but rather as a collective societal responsibility to provide an enabling environment for a woman to carry out her infant feeding decisions. A number of factors beyond the health sector contribute to this environment. Adequate maternity protection, workplace breastfeeding policies, protection from the inappropriate marketing of infant formula, as well as support within in the community and in families. But an enabling environment within the health sector is of critical importance, particularly as more and more women are delivering in facilities. So the Baby Friendly Hospital Initiative was launched in 1991 by WHO and UNICEF to further the protection, promotion, and support of breastfeeding in maternity facilities around the world. It really sought to incentivize the adoption of policies and care practices for the successful early initiation, skin-to-skin contact, early initiation, which Kelly spoke to, as well as exclusive breastfeeding. It is based on a series of 10 steps outlined in the global guidance. And since 1991, it's been estimated that over 20,000 maternity facilities have been designated as baby-friendly, and thousands of health workers trained through different training programs. And a number of systematic reviews have shown that the initiative has proven impact on increasing the likelihood of babies being fed only breast milk for the first 6 months of life. That said, scale up to full coverage and long-term sustainability while maintaining quality have proven challenging in many countries. And these have been summarized in a recent WHO report as lack of government ownership. I mean, speaking to Richard's final slide on what you need for a strong integrated program. The voluntary nature of the implementation, the vertical approach, I think we've heard that from both speakers, and maintaining momentum and funding over time, and the recurrent costs of training and assessment. So benefiting from 25 years of experience in the implementation, WHO and UNICEF are now revising the guidance to address these limitations. And in particular, and this gets to the whole health service strengthening component, this new guidance seeks to promote the integration of the initiative with other healthcare improvement, as well as quality assurance initiatives to promote sustainability over time. I mean, we're not going to do it. We're going to use other QI mechanisms to integrate the practices that we would like to see. And it also seeks to incorporate or align with other WHO and UNICEF technical guidance, including the WHO framework on integrated people-centered health services, as well as the WHO standards for improving quality of maternal and newborn care in health facilities, among others. So the goal is to have, obviously, a much less vertical approach, but also to focus not just on clinical practices, but also some key management practices in terms of just the structure of the facility as it promotes early initiation, skin-to-skin contact, and other practices that lead to better breastfeeding outcomes. The second example really relates to the community-based management of acute malnutrition, or CMAM, as it is known in the nutrition and health communities. So in 2016, WHO and UNICEF joint estimates reported that about 16.4 million children less than 5 years of age suffered from acute severe malnutrition. And this is, what I talked about earlier. This is the emaciated child that's at significant risk of mortality from malnutrition. Of these, about 12 million live in Southern Asia, and about 4.3 million live in Africa. And the larger number in Southern Asia reflects both the higher prevalence as well as the larger populations. It's caused by inadequate feeding, diarrhea and their interaction, as I mentioned earlier, HIV infection, and many other illnesses. It remains a major killer of children under 5 years of age, with case fatalities exceeding 20% in some settings. So traditionally, the treatment was restricted to facility-based approaches, which greatly limited its coverage as well as impact. The facilities weren't accessible. Parents were often unwilling to send their children to hospitals, which were associated with death. Admitted children have severely compromised immune systems and therefore, risk exposure to other infections within the hospital. And then when these children, when they recovered and discharged, the parents didn't have the skills. They didn't have the connections within other community-based facilities to manage, continue to manage them so that they didn't relapse. But during the early part of the 2000s, a growing body of literature showed that many of these children that didn't have other complications could be treated in communities without being admitted to a hospital health facilities or therapeutic feeding center. They could be managed in the community, live in their households, but have access to that community platform for services, which again goes back to, I think, comments both by Kelly and Richard as the importance of this community engagement and utilizing these community-based platforms for this integrated service delivery, including that related to treatment of severe acute malnutrition. So in 2007, WHO and UNICEF issued guidance on the community-based management of acute malnutrition, CMAM. And this approach involves a timely detection of severe acute malnutrition, provision of treatment for those without medical complications with what we call ready-to-use therapeutic foods or other nutrient-dense foods at home. And so it's a specialized food that is available in the health facility that then the parent can take home and feed to the child. And it's formulated in a risk that you remove risks of contamination and so you're feeding something nutrient dense and not risking infecting the child with a foodborne illness because it's not a hygienic food. And if properly combined with the facility-based approach, again, for children without major medical complications, and implemented on a very large scale, the management through this way has prevented the deaths of hundreds and thousands of children. So I'd just like to conclude with a few key messages. First, I hope I've made a convincing argument that early childhood feeding and nutrition is a key component of early childhood development and vice versa. I mean, nutrition is not just important to prevent death, but really to promote their well-being early in life and later on. And that integrated health system delivery models, such as breastfeeding promotion through the Baby-Friendly Hospital Initiative, as well as community-based management of acute malnutrition, can improve child nutrition and leading to better child development outcomes. Thank you.
Thank you. Well, I personally am convinced, admittedly feeling a little bit guilty for not breastfeeding a little bit longer for my 3 kids.
Are you feeding your kids okay then?
Yes, exactly. No, that's great. But also just very helpful for you to dive a little bit deeper into to help us, better understand what that means in terms of how to effectively integrate nutrition and what that means for early childhood development and giving examples of the Baby-Friendly Initiative and CMAM. So now I'd like to open it up for questions and comments. It's your turn, so thank you for being patient. I think we have time for a couple rounds, so I'd probably like to take maybe a couple at a time, and then the panelists can have time to address them. I think you're go ahead, and then you, and then Sunita, you can go ahead. Thanks, Julia.
Thanks. Is that on?
Yes.
Thanks. All those presentations were amazing. A lot to think about. I have so many questions, but of course I'll limit myself to one because I know a lot of other people have questions as well. I think everybody touched on the role of communities, and I think we've always known that communities are important, but I think there's been a lot of really solid evidence over the last, say, 10 or 20 years about communities, and I'm just wondering about what you think you've touched on specific individual examples, CMAM, community case management, HEW systems, in Ethiopia. But are there any kind of lessons to be drawn about how best to integrate the community with the rest of the health system? Because too often they seem to be one might function well, but not necessarily be articulated with the other. And one thing in particular is the kind of power dynamic, I think, that happens a lot, that those who are community health workers, et cetera, are probably the least powerful elements within the health system, people within the health system, and least well able to advocate for themselves. And so all too often, I think, get the least number of resources. So just be interested in people's impressions and experiences on that.
Thank you. And can you let us know who you are, please?
Oh, yeah, sorry. Jim Recca. I work with the Maternal Child Survival Program.
Thank you. And then this lady, next row, had her hand up first. Thanks. Great.
Hi, thank you so much for all of your talks. It was so impressive and very enlightening, and I really appreciated it. My question is sort of at the integration of all of this very fascinating data into the humanitarian space, which is sort of, now there are discussions of kind of merging it with the development space. And I was wondering if you had seen any patterns or compelling data that would make this applicable or at least less hard to apply in the humanitarian settings, because there are just some issues in the humanitarian space that I think we can't really get through. I am a policy analyst at the Center for Health and Gender Equity.
Great. What's your name?
Oh, Noor Shakfi.
Okay, great. Thank you. Good question. Well, let's take one more. I think Sunita, I think you had your hand up.
I'm Sunita Sharma from Palladium. Excellent panel, really good presentations, and especially I loved the flow, these specific examples. So Richard, thank you very much for presenting that example of how integrated health systems can produce such impressive outcomes. But I was very interested in knowing more about the financing side of it, because you mentioned that countries are committed to provide free ACTs and all those things, but can you comment on financial sustainability, and especially as you also mentioned that people are also going to private sector. So out-of-pocket expenditure, what's the plan to show that there's financial protection as well as coverage for the vulnerable population?
Good.
Especially covering the financing.
Thank you. Good. All good and diverse questions. Let's stop with 3 for the moment and then take a second round if you don't mind. Kelly, if you could start us off maybe addressing potentially the first question. Is a question about community and the involvement and integration in this topic. There was also a question about the issues and the bottlenecks and specifics in the humanitarian space and how we can apply what we've kind of learned throughout the panel. And then I think, Richard, you could take the question related to the out-of-pocket expenditures.
Sure. So I fully take the points on the community. I mean, we've done a lot on community-based services, and a lot of times I think our work with communities views them from a health service, health system perspective as an extension of the health system. So we've got community health workers that are going out and doing work in the communities. And I think it's important for the power dynamics that you talked about to recognize that communities are systems in and of themselves, that are dynamic systems that have individuals that work together for more than just health, but also that health is clearly an important component to them. And so rather than figuring out how do we push down community-based services from a health system, how do we recognize the value of that community system and what it brings to the table and better link it to the health system as a separate system? I don't think we've fully answered that. USAID has a partnership with UNICEF, which is starting to explore some of the options around that and sort of see what lessons we can learn about recognizing community systems and how to better link them to overall health systems to improve health. And then on the humanitarian piece, I don't know if I'm going to fully answer your question, but in my view, the 2 parts where what we do in health systems and services where I think have the biggest impact on the humanitarian space is one, before humanitarian emergencies occur, and making sure that health systems are resilient and strong. There's the global health security agenda, but also what else can we do to make sure health systems are prepared to respond to whatever shocks may occur, be them sort of natural disasters or conflict or other aspects, and how to make sure that services can continue. And so I think that's work on more of a preventative side within the health system that I think would lend a lot to sort of when humanitarian issues do occur, helping to mitigate some of that. And then the other piece is in that transition from humanitarian back to development and back to longer term programs, which I think is something we often struggle with. And so I think better being able to define and prepare for and manage that transition so it's as seamless as possible so that humanitarian actors are freed up to address humanitarian needs when they occur, but then also to figure out how to more quickly transition them back into a development space and a health system space where we're continuing to work on those issues.
Thanks. Jessica, do you want to
I
come
couldn't
in?
agree more with your comment about communities being systems in and of themselves. Because I think when we think about certainly nutrition and child development, it happens obviously outside the health system sector. I mean, there's a contribution from the health system, but really it's about empowering families and communities, making communities aware of the situations in their own communities. For example, the example I gave earlier about these girls in Ecuador, and this has happened in several communities in Latin America. I mean, Peru has done a lot on this. There'd be a program or initiative whereby children would be measured in the community, and then they would, just plot, so the community themselves could see that, the degree of stunting in the community. I mean, not to single out any individual child, but, you should only have 2.5% if you're looking at a normal distribution for a child, less than 3 standard deviations, or, 13 point something percent if it's less than 2 standard deviations, a cutoff for stunting. If you've got 40 or 50, it's a way for the community to see the problem, and then work as a community and interact with the health sector as appropriate to really start addressing some of these underlying causes and drivers. But also with respect to this health system, there's a number of countries in Latin America. Brazil is one, Paraguay is another. There's others where, these community volunteers are paid. I mean, these are low-income, very low-income people, and, they're not being paid for their services. They have other things to do. They're not just sitting around waiting to go visit these households and talk about visiting the prenatal clinic or getting your child immunized, or are they feeding the child correctly? And so they've really integrated the community worker as part of an overall medical team. And the person is paid. And they have the team is assigned certain geographic responsibilities for households, et cetera. So again, my experience is in Latin America. I don't know how common this is in other regions, but it's a way to have, somewhat address this lower status of these, as well as to integrate, what's going on with what the community member knows with, what the health services need to know in terms of, we need to be sure these, women are coming in for antenatal checks, or, this child seems ill, let's bring them in to test for malaria, or something like that. Humanitarian space, well, obviously that's where severe acute malnutrition is often a crisis there. It's also, so in terms of humanitarian assistance, usually there's a huge scale up to address this. But as well, to be sure that we're adequately protecting breastfeeding in the situation. Often the first response is, let's get formula in there. And it's not necessarily the right response at all, particularly if you're in a camp with unhygienic conditions. That could be a death sentence for a baby. So in Haiti, for example, what UNICEF and WAPAHO did is they set up what they call baby tents, safe places, where a mother and her young baby could go, to breastfeed and just have that quiet, safe space to be sure that baby was, properly nourished.
Thanks for that. Okay. Richard, go ahead, please.
Yeah, just before I address the financing issue, just one comment also on the humanitarian and kind of complex emergency kind of side of things. One good example I can mention there is in Guinea. We are actually implementing a PMI funded malaria program, where we integrated malaria case management in the community health worker platform in Guinea. And as the Ebola outbreak happened, actually vertical programs, or much more vertical programs such as HIV and TB, completely collapsed, whereas we were able to, with the Ministry of Health and other partners, to maintain the community health worker platform alive throughout the Ebola outbreak. So even though they didn't provide diagnostic testing at some point anymore, they still did provide presumptive treatment of malaria cases, which probably has softened quite a bit the impact of the Ebola epidemic on the burden of malaria at that time. We know that because of Ebola, actually the burden of malaria, because of the disruption of services and supplies and so forth, increased, but certainly that increase probably was softened because that community health worker platform was still operational. And so it really goes to this point of, how resilient are some of these platforms and systems when an emergency such as Ebola happens. With regards to the question around financing and sustainability, I mean, I guess in terms of the free diagnosis and treatment, really the policy kind of came also on the heels of actually free distribution of insecticide-treated bed nets. So for a number of years, there was quite a push of, for example, social marketing approaches around insecticide-treated bed net distribution. What really was seen is that while some of these approaches obviously have merit in certain geographies, the kind of level of coverage that you would want to really impact the burden of malaria just did not happen. And so really on the heels of that, pretty much a global policy decision was taken to, provide essentially the main malaria interventions, including diagnosis and treatment, free of charge to most populations at risk, especially in rural areas. So that has happened now for a number of years, and I would say malaria is not the only program that now has to have that hard discussion around financing and sustainability. I would say, if you look at global health funding in the last year and certainly going forward, there is a slight decrease, and countries almost have been sort of in the heyday of global health funding, have been pushed to scale up to levels that actually aren't sustainable anymore. If you look at certain countries, including Ethiopia actually, they've been told, scale up essentially all malaria interventions in all malaria endemic areas. But that obviously comes at a huge price. And so what has happened is that, sort of almost epidemiological thinking has gone out of the window, and that they treated essentially entire countries the same. So it didn't matter whether you had, maybe just one case in one district, but 1,000 in another. Essentially, you treated every geography the same. And of course, I mean, that's poor programming, right? So it's kind of, I think, now where we have to sort of dial back a little bit, where we really have to look at the epidemiology, the data that's coming up through the data reporting or the health management information system to really target interventions much better. And malaria is not the only program. I mean, HIV is dealing with the same things, TB and others as well. And so in a way, get smarter in terms of the targeting and increasing the efficiency and effectiveness of our interventions. And then, of course, also engaging host governments as well as districts and communities to take ownership of the programs, and including actually financing them. I mean, one figure in the latest World Malaria Report is that, for example, right now, external donor funding very much focuses on commodities and providing those to host governments, whereas actually host governments' contribution overall, 50% go to health systems strengthening. I mean, this goes from, infrastructure facilities to essentially, obviously, the salaries of the health workers and so forth and so forth. So I think governments are stepping up in their own contributions to fund malaria programming, but certainly other approaches need to be considered as well. So whether this is again, subsidies, for example, in cases like Nigeria, Nigeria does actually subsidize the price of ACTs in private sector facilities, which comes again at quite a cost, but certainly to lessen the blow to the population. And then also in terms of, for example, health insurance and other approaches to kind of going forward make those things or make the programming more sustainable. Because
I'm going to stop you there.
Yep.
Go ahead. I just want to give a couple more round of questions. We've got 10 more minutes. I know there's a lot of people. We covered so many different topics that I think that you guys are coming from a variety of different topic areas. So I want to give you the chance. So the two gentlemen over here, and then we'll do one on this side. I'm not sure whose hand was first. Jennifer, can you help me? And then we'll ask your question or your comment to be brief, and also the panelists' responses to be brief as well. Thank you. Who's got the mic? Oh, there we go. Oh, yes, please.
Great, thanks, and thanks to all the panelists. The presentations were great. They focused a lot on the integration of health systems at the facility and the community level. My question is, what's happening above site in terms of integration of health systems at the health system manager level, at the district, the subnational level, and the national level? What do you see as emerging priorities in strengthening health systems integration above site?
Good question. Can you introduce yourself, please?
Sorry, Jacob Hughes, USAID.
Thank you.
Thanks to the panelists, Carl Henn, American International Health Alliance. I want to go back to earlier, Kelly, you talked about a tool that USAID is using, LIST, I think you called it, to estimate lives saved due to health system strengthening. And I wondered if you could talk about the extent to which host governments have embraced or adopted the use of this tool and how that affects their planning and budgeting.
Thank you. Great. And let's take one on this side. Please.
So I had one more question similar to the financing question, but more in terms of purchaser incentives for introducing integrated health system delivery models or scaling those up, if those exist and what your experiences with those have been.
Great, thank you. Let's just take those three and let's have some brief remarks from the panelists. We have one on health management and on the LIST model in terms of planning and budgeting, and also the health financing question. Don't feel compelled. You don't have to answer, or you can, skip and take the next round as well. Thanks.
Sure, I'll try to be brief so I won't offer all my thoughts on all of those questions. But so one thing I think that is clearly a need at sort of this second level up set of integration is the district supervision of facilities and health workers. A lot of times you get one supervisor who is going out for a malaria program on Monday and a child health program on Tuesday and that sort of thing, and whether or not we can figure out how to integrate at that supervision level of how services are being provided. Then there's more that could be said, I think, on health information systems and financing as well, but I will let that go. So the tool to ask it's actually two tools. They're built together. One is the Equist tool, which UNICEF has developed and is rolling out. That is really the innovation that enabled the health systems intervention piece. So Equist does all of the work from health systems interventions to the point where it figures out what's the change in intervention coverage. And then that's the piece of information that we program through LIST. LIST is developed by Johns Hopkins. It's actually already integrated into a bunch of other tools that countries use. So it's part of the One Health tool. It's just the LIST tool, and now it's part of Equist. So in Equist, we sort of used a modified version of Equist to look across 25 countries. If you were really to apply it, it's meant to be used for country level planning and that sort of thing. So UNICEF is still rolling out, I think, the country level use of the health systems integrated piece, but we hope that that gets rolled up. And then things like the One Health tool and lists are pretty widely used in countries. And then just finally on the, I'm not 100% sure what you mean on the purchaser incentives, but at the very macro level, there's a lot of conversation around cash on delivery aid and results-based financing at the donor level that I think are innovative things that we're exploring and sort of seeing how they go. We know that results-based financing at the country or provider level has a lot to it that you need to get right in terms of setting the incentive right and verifying and how you track it and all of that. So I think it's sort of a new frontier at the donor level that is certainly part of the conversation that we're looking into.
Thank you. Thank you. Jess and
Yeah,
Richard,
just really
did you have
briefly,
anything?
the first question, and I was going to touch on the health information systems because as information flows up, from community, district, province, national scale, it can really help address the targeting that Richard was talking about. Using this local information to, okay, we're doing well on this aspect of child nutrition here. We really need to start focusing more on these other, highland, indigenous, low, or peri-urban, very poor peri-urban communities. I think there's a huge role and I think partly what can be a huge challenge and a detriment is kind of sending all the information up and then not using the information for local decision making. But at the same time, certainly, I think in my experiences in Latin America, getting the right amount of data at the senior level, or the ministerial level, then to really figure out how you're going to best target resources to address certain, in the context of nutrition, really what we're seeing in terms of different nutrition outcomes.
Do you have anything to add? We're waiting for the next question.
I don't have, I could talk much more about some of those things, but I don't right now have anything to add. I think.
Let's get two more questions. And then, feel free to stay. This room is open afterwards, so feel free to, approach the panelists as well. We could take three maybe quick. Yes, go ahead, please.
Yeah, thanks very much to the panelists. My name's Craig Burgess from JSI. And so you made very good technical justifications for integration, and many people see it as the holy grail. Others see it as a poison chalice. So my question is more political on financing, and it goes along the lines of kind of not everyone sees the advantages of integration. So, for example, individual programs might not see the advantage, individual careers might not see the advantage, funders might not see the advantage in terms of attribution in this contribution debate. And institutional survival also depends on lack of integration. So I'm wondering whether the panel had any thoughts on what incentives, either political or financial at country level, can we help implement or support to make sure there's more dialogue and support for the integration agenda as UHC pushes forward. Thanks.
Thank you. Good question.
Hi, good morning. My name is Peggy Duback, and I'm interested in children's literacy acquisition. So I want to think about integration from a standpoint of what's the interest of the global health community to integrate with the education and language community. We know that we have some effective models of wellness visits and early mother-daughter, mother-baby checkups as an opportunity to develop responsive language. So I'm just interested in what is the interest of the global community to work more collaboratively that way.
Good question. And the last one over here.
Thanks to all of the panelists. My name is Kate Wolf. I'm also with the Maternal and Child Survival Program. I've a question about quality of care from two perspectives. Several of the panelists mentioned working with the private sector and also all of the work that's being pushed out to community level. A lot of the countries we work in, the community health workers are supervised at the facility and not in their communities. And I'm wondering how we can appropriately get feedback on the quality of care that's happening at community level when there's not a lot of actual observation of those interactions, recognizing that there's a huge expense that goes along with it. So how can we approach that pragmatically? And in the same lens, looking at using services or subsidizing services in the private sector, how can we ensure that there is transparency and that there is responsiveness in terms of submitting data to the HMIS, and also ensuring that there's an adequate quality of care provided in those facilities, in those settings?
Great, thank you. Those are really big questions within 2 minutes' time. I don't want to get cut off by the webcast, and I know that discussion can be continued, but if you choose to kind of comment on one or two of those, that's great. I think the question is great about kind of not everybody thinks integration is a good thing, so politically and financially, if you could comment on that, as well as the community quality of care as well.
Sure. So
and multi-sectoral in terms of education, I didn't forget.
Okay, so really quickly, one I think is making sure that we're not pushing an integration agenda because we want to push an integration agenda. I think the agendas we should push are the agendas focused on improving morbidity and mortality and outcomes. And I think if you really analyze that, I think the way we've done, it leads you to an integration agenda, but making sure you're doing it right. But I think where we go off the rails is when we say, let's just do integration because we want to do integration. And then I think similarly on the literacy, I'm happy to talk, I won't go into it now, I think on some of the Zika work, we've done some work looking at that. Beyond that, I think there's interest, but it's hard to find those right points of intersection because a lot of the health work is focused on the mortality components. And so where those intersections, if we can find them, I think we're happy to work on them, but they're hard to find. But I have some thoughts on Zika. And then on the quality, I think it's the same thing I said before, is there's some really good work on social accountability and using the community system to look at some of that accountability and ensuring quality and not necessarily pushing everything from the health system down.
Thank you.
So, okay, well, I'll maybe add to the integration discussion. I mean, I would say in terms of approaches and incentives, I think, you know, what you really want to work with ministries of health and health workers is to, as Kelly said, show that integration isn't just done out of the sake of integration, but it makes sense. I mean, I mentioned, for example, the various malaria interventions that are being done. For example, IRS, the spraying of households with insecticide, would be very difficult to kind of integrate in sort of overall health service delivery, so to speak, versus case management, which is sort of that natural fit, if you think of integrated community case management of fever, let's say. So it's kind of really looking at, well, what interventions have to be done more vertically versus horizontally. Then in terms of for health workers themselves, I would say it's also to really kind of show them that by you know, having roles and responsibilities in integrated service delivery, they're also improving their actual skills and career opportunities. So if I think of, for example, you know, a laboratory technician, if that laboratory technician only does malaria diagnosis, of course there will be very much restricted in terms of possible career choice and pathing going forward, rather than if they actually would be laboratory technician across the board and be able to, you know, work on all kinds of infectious diseases at facility level. So I think there's certain approaches there that really, you know, already are happening and could be further developed to kind of push that forward. And in terms of the sort of quality of care in the private sector and community level, yes, social accountability is certainly one approach, and back to the sustainability and financing point of view, it's really also getting the community involvement to kind of be able to take ownership of sort of that private sector as well as community level service delivery that is happening, to then kind of monitor quality of care as well. And various approaches there that certainly beyond social accountability are feasible. I mean, whether it is some out-of-pocket or small out-of-pocket expenses coupled with incentives and subsidies, but also really sort of having that engagement with the community going forward. So certainly things are happening in various settings there.
Thank you, Richard. I am going to have to end this. I know that thank you for staying a couple minutes late, and sorry, Chess, I didn't get your last words, but please approach the panelists as you'd like. And you know, I'd like to give the panelists a round of applause. Thank you very much. It was a heavy task to ask them, and I came, you know, asking a big ask to really unpack the data and really help us understand what it means in terms of integration matters, in terms of effective, efficient, quality care that's cost-effective for the person at the person-centered care. So they've done that task very well, and also thank you to Erin Williams, who's my colleague and global leader and a great advocate for global health and maternal child health. So I appreciate you giving those opening remarks, and thank you for being being here, and have a great rest of your day. Thank you.